mentors, guides, and in many ways are second parents. I would like to welcome Dr. Deepak Chavan sir, Associate Professor, General Surgery, Dr. Shri Lata Devi ma'am, Chairman of SARS. Let's start this event by remembering how the last event, Medical Mysteries, helped us in sensitizing ourselves to the culture of paper presentation and case report presentation and creating confident speakers and presenters. With that spirit, let's commence today's session of some striking presentations to boost ourselves with knowledge and confidence. All the presenters and judges, please note the rules for the presentation. Each speaker can speak for a maximum of 7 minutes. One bell will be rung at 6 minutes. Two bells will be rung at 7 minutes. This will be followed by a 3-minute discussion with our panel of judges. One bell will be rung at the end of 3 minutes. We wish all the contestants the very best for the presentations. So now we would like to begin with our first contestant of the day, slot number 1, Rakshit Pandey from second year.
Slot one of the first presenters. One. Still have the marks. The marks. One. Only one. It is where Hindu ma'am must not hold. Certainly slot 1 to names and the top.
Ma'am. Arushi. It's not open.
All these files are showing this one. Wait, I'll open it also to the camera. It's not coming on this one. I'll do it on the digital.
Slot number 2 is the same person that topic.
I'm so sorry. Ma'am, the pen PPTs are not working. 2 minutes.
If she is not ready, then ask other person.
All the PPTs are not working. Yeah, because I downloaded and added it to a file, but then they're saying it's not working on the file.
PPT open again. Okay, then no problem.
Upload it in the
Ma'am, I came and the seniors were making the PPT on this laptop and they were not giving me the laptop. The seniors. I got the laptop at 250.
Why are you allowing others to prepare PowerPoint?
They were doing it on this.
Who was doing it? I don't understand what.
So next time you have to prepare your PowerPoints beforehand and come and upload it in the laptop. Please don't prepare the PowerPoints here. Whoever have done today, this is the last excuse.
They have prepared PowerPoint on this one. She didn't get the chance to upload her.
Yeah.
It's not starting. Seniors are doing PowerPoint.
Done.
On.
Rakshit says that.
What is this here? They should do. No one is allowed to prepare the PowerPoint.
I can start? Good afternoon, respected panels and everyone else present in this room. I am Rakshit Pandey, second year MBBS student, and I will be presenting my case distinguishing benign from malignant Hurthle cell tumors. So for this, a patient, 68-year-old female, hailing from Vijayapura, came presenting complaints of swelling over anterior aspect of the neck since 1 year. The history of presenting illness. Patient was apparently alright 1 year back when she noticed swelling over anterior aspect of the neck, which was insidious in onset, gradually progressive in nature and not associated with any tenderness, discharge or pigmentation. The initial size was 2 into 2 centimeters, which progressed to 8 into 8 centimeters. The negative history. She had no history of pressure symptoms like breathlessness, difficulty in swallowing, no history of loss of weight, no history of trauma, no history of pain or fatigue. The past history. Not a known case of hypertension, diabetes mellitus or any cardiac disease, but she has a known case of seizure since 30 years and is on medication since last 6 years. The personal history. Diet was mixed, appetite good, adequate sleep, and bowel and bladder was normal and regular. Nothing significant on the family history side. The general physical examination. A 60-year-old female, moderately built and nourished and well oriented to time, place and person, with normal vitals and absence of pallor, rectal, cyanosis, clubbing, lymphadenopathy and edema. On local examination, the patient was examined in a well-lit room in sitting position and the region from the chin to the xiphisternum was exposed and examined after taking consent. On inspection, found solitary swelling over the anterior aspect of the neck towards the right side of the size 10 into 8 centimeters, oval shape. The margins of swellings were well defined. Swelling was moving with deglutition and protrusion of tongue. No scar marks, pigmentation over the swelling was present and no protrusion of the eye. On palpation, there was no local rise in temperature, no tenderness present. All inspectory findings were confirmed. Solitary swelling, firm in consistency, central trachea, bilateral carotid pulse was present, no pulsation or thrill over swelling, and no palpable lymph nodes. The systemic examination, the CVS S1 and S2 heard normally, no murmur. RS was normal with vesicular breathing, sound heard. And per abdomen examination, we found soft, non-tender, no organomegaly. On investigations, laboratory indices demonstrated normal limits of TSH, free T4 and free T3. Neck ultrasound showed thick-walled heteroechoic lesions occupying whole of right lobe with a TIRAD score 4, which suggested suspicious for malignancy. Now the FNAC, fine needle aspiration cytology, showed high cellularity comprised of large polygonal cells with nuclear pleomorphism, prominent nuclei, and was reported as suspicious for malignancy again. So the treatment. A total thyroidectomy was done with intraoperative frozen section examination. Grossly, right lobe of thyroid was enlarged, measuring 8 into 8 into 4 centimeters. The left lobe of thyroid measuring 4 into 2 into 0.5 centimeters, and the isthmus measuring 2 into 1.5 centimeters. The cut section of the right lobe showed a capsulated friable hemorrhagic mask. The microscopy showed compact microfollicles with scant colloid and was repeated as suspicious for malignancy. Now the histopathological findings for this case. Later the specimen was sent for histopathological study where it revealed a well-encapsulated tumor showing oncocytic cells with abundant granular and eosinophilic cytoplasm arranged in micro and macro follicular patterns. At places, papillary pattern was also present. Peripheral thyroid tissue showed features of nodular goiter. No evidence of vascular or capsular invasion was seen in around 60 sections after extensive grossing. A diagnosis of Hurthle cell / oncocytic adenoma in nodular goiter was rendered on histopathology. So what are Hurthle cell tumors? Hurthle cell adenomas are non-invasive encapsulated tumors which are surrounded by a thin capsule and characterized by cells with abundant granular eosinophilic cytoplasm with prominent central nucleoli. Hurthle cells tumors have been called as oncocytic tumors or oxyphilic tumors. They have been found in association with various benign thyroid conditions like Hashimoto thyroiditis, hyperthyroidism, nodular goiter, and thyroid neoplasms, where they were often represent oncocytic metaplasia. Hurthle cell adenoma of the thyroid is a rare benign thyroid neoplasm composed of oncocytic cells that compromise more than 75% of adenoma cell population. However, controversies about its potential malignant behavior still remain. Hurthle cell remains are distinct, not only because of the enduring debate about the true nature, but also because Hurthle cell carcinomas are particularly aggressive, thereby emphasizing the need to differentiate the HCAs from the carcinoma. In our case, although being a benign tumor on histopathology, shows feature of malignancy on imaging, cytology, and on frozen section. These are my references for this case study. Thank you.
Any questions from the audience? I just like to tell you one suggestion.
Yes, sir.
Add logo in all the slides, right? And if possible, at the corner, the presenter name, your name. Okay? Second thing, the last introduction what you were giving about Hurthle cell carcinoma, better it should come in the first, right? The first is introduction, then history, then you present it. Understood?
Yes, sir.
Okay. This is my suggestions. Fine. If anybody would like to add. Okay, next.
Thank you, sir.
Now at slot number 2, we have Vidisha Shringi from second year.
A very good afternoon to all the judges and everyone present in this room. I am Vidisha Shingi, studying in second year. I'll be talking about multifactorial congenital anomalies, a case which highlights the study of importance of fetal autopsy. I will be covering these topics. So congenital anomalies are also known as birth defects. They are structural or functional abnormalities that occur during the intrauterine life. They are the leading cause of infant mortality and long-term morbidity. These anomalies can result from genetic factors, environmental exposures, or nutritional deficiencies. The accurate diagnosis of congenital anomalies is crucial for effective management. Early identification through prenatal screening allows for a better planning of care, including potential interventions and informed decision making. Moreover, understanding the specific nature and cause of anomaly is vital for providing genetic counseling, assessing the risk, and guiding future pregnancies. Here are the case details. So a 20-year-old female came for a prenatal checkup at 18 weeks. Her last menstrual cycle was on 27th Feb and her estimated date of delivery was on 4th December 2023. Her obstetric score was gravida 2, para 1 and living 1. Negative history consists of not a known case of diabetes, smoking, or known case of exposure to organic chemicals or pesticides. Her marital history was a non-concisus marriage, and family history, there was nothing remarkable or any genetic disorders. The first trimester, folic acid supplements were taken and dating scan was conducted during the first trimester. The dating scan appeared normal. Second trimester, quickening was felt and anomaly scan at 18 weeks revealed single umbilical artery, normal liquor, sacral meningocele and bilateral hydrouteronephrosis. Here are the impressions of the scan. The clinical management and diagnosis. Counseling was provided to the patient and decision to terminate the pregnancy due to suspected OEIS complex was made. The fetus was sent to the hospital for autopsy. So what is OEIS complex, you will ask? OEIS complex or clonal exostrophy is a rare syndrome that affects the lower abdominal wall of infants. It is often diagnosed before birth with the fetal ultrasound and it's confirmed at birth. It includes omphalocele exostrophy, imperforate anus, spinal defects, neutral tube defects, club feet, polydactylity and missing limbs. OEIS complex may be caused by a single gene defect in early mesodome development. The fetal autopsy and its findings. So a male fetus weighing 350 grams was sent and the external examinations of the fetus, including the anthropoetic measurements, were as follows. There was no evidence of polydactylity and the key external findings were as follows. A sac which was noted at the insertion of the umbilical cord over the umbilical region measuring 3 into 1.5 centimeters and a cut section of sac showed intestinal coils suggestive of omphalocele. Single umbilical artery and normal limbs. The internal examination of the fetus. The cardiovascular system, the heart measured and weighed normal. The respiratory system had right lung weighing 6 grams and it was bilobed. The left lung weighed 5 grams and the ratio of the left lung to the body weight was 0.012, which is below the limit of gestational age. The abdomen internal examination reveals liver and spleen which were normal. The right kidney measured 2.5 into 1.5 into 0.5 and weighed 6 grams, and the cut section revealed many cysts in the cortex and the medulla. The left kidney was also dilated, and it was found to have many cysts in the cortex and the medulla. Focal segmental intestinal arteria measuring 1 centimeter in small bound. Additionally, the fetus also exhibited an imperforate anus, a condition which is marked by the absence of a proper anal opening. The histopathological analysis. So sections were studied from bilateral lungs, spleen, thymus and the brain, which revealed normal histology. And the liver hepatocytes were arranged in cords. There were normal sinusites, and there was mild increase in bile ducts with periportal fibrosis and the presence of plasma cells. Lymphocytes around the portal tracts were suggestive of periportal fibrosis. Here is a slide of reticulin stain which shows periportal fibrosis. The fibrous part appears blackish. The kidney. Cortex and the medulla of the kidney showed many fusiform cystically dilated spaces by flattened low cuboidal epithelium arranged in a papillary pattern. Few medullary cysts showed interconnections with cortical cysts. Areas of hemorrhage in the medulla were also noted. There was no evidence of immature cartilage present in the kidneys. This was reported as bilateral polycystic kidney disease. The differential diagnosis. The ultrasound reported initially indicated OEIS complex along with a possible meningocele in the sacral area. This complex, the OEIS complex is often associated with other malformations such as clubfoot, hydroureter, and body stalk abnormality. However, the absence of sacral meningocele and characteristics were not aligning with OEIS complex on fetal autopsy. This necessitated the re-evaluation of the diagnosis. The exclusion of gastrotritis and the identification of omphalocele shifted the diagnosis towards the chromosome abnormalities, namely chromosome 18 and chromosome 13. The single umbilical artery, the left pulmonary hypoplasia, and the bilobed right lung with the omphalocele and the presence of polycystic kidneys are closely aligned with the characteristics of abnormalities of chromosome trisomy 13. So here are the positive findings and the negative findings. So positive findings of trisomy 13, omphalocele, single umbilical artery, abnormal lobulation of the lung, which was the right lung, multicystic kidney and pulmonary hypoplasia, and trisomy 18 positive findings from omphalocele, multicystic kidney and 2-vessel umbilical cord. The negative findings were cleft lip and limb abnormalities. There were no limb abnormalities in the fetus. And the negative findings for chromosome 18 were web neck and cardiac defect. So the role of fetal autopsy. The bilateral polycystic kidney disease is a condition that can be identified in unborn babies through prenatal ultrasound with further confirmation provided by fetal autopsy. Another case which emphasizes the importance of fetal autopsy is by Satyanarayana et al., which described a similar situation where ARKPD was detected before birth and confirmed by autopsy after delivery. These cases emphasize the significance of early diagnosis and the confirmation of role of fetal autopsy, which can help in offering genetic counseling and planning for future pregnancies. The diagnosis of this congenital anomaly was confirmed through a detailed autopsy as genetic testing was not possible due to formalin fixation. The autopsy...
Time is over. Cut down your slides, cut down the matters. Slides are overcrowded. And images in the slide should belong to the case. Don't take any image. This is not a seminar or any other thing. Here you are presenting. Slide number 3 has an image of different doctor doing different patients. Can remove all those slides. Fine? Okay,
So what are the indications for medical termination of pregnancy?
Bleeding, per vaginal bleeding.
MTP, medical termination, where baby is alive but still this is one condition, no?
Yes, ma'am. Down syndrome, any genetical abnormalities. And
So any maternal cardiac disease?
yes, sir.
We should know all the indications. Okay.
Thank you.
Now on slot number 3, we have Prerna Menon from 4th year.
Good afternoon, everyone. So today I'm Prerna Mannem and I'll be presenting the case of Morvan syndrome. I'll be presenting the case of Yalaling Basappa Hippargi, who's a 25-year-old male from Mulsalavagi Taluk, Devar Hippargi. The patient came with chief complaints of abnormal twitching in the calf muscle since 3 months. He also complained of pain in the lower back since 3 months, pain in both the lower limbs since 3 months, and reduced sleep since 3 months. History of presenting illness. The previously healthy patient gave a history of lifting heavy objects 3 months ago, after which he developed a burning type of pain in his lower back region radiating to the lower limbs, which was continuous in nature and associated with tingling sensations and numbness. He also had abnormal visible muscle twitchings accompanied by painful muscle cramps. The patient also complained of reduced sleep, which was 2 to 3 hours per night for the past 3 months that got progressively worse. He had no history of seizures or abnormal behavior and had intact memory. There was no history of recent weight loss. Past and family history. The patient is not a known case of diabetes mellitus, hypertension, epilepsy, asthma, or tuberculosis. He has no previous histories of surgery or blood transfusions, no history of drug use or drug allergies, and no significant family history. A general physical examination. Here is a male patient, moderately built and nourished, conscious and oriented to time, place, and person. His pulse rate was 76 beats per minute. Blood pressure was 150 by 100 millimeter of mercury. Respiratory rate was 22 cycles per minute, and there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. On head-to-toe examination, everything was normal except the lower limb where bilateral fasciculations were appreciated. Systemic examination. On CNS examination, the patient's higher mental functions were normal. Motor examination revealed bilateral calf muscle neuromyotonia, but muscle strength, tendon reflexes, and sensory tests were normal. There were no cerebellar or meningeal signs. RS, bilateral air entry was present, normal vesicular breathing sound was heard, and no added sounds. On CVS examination, S1 and S2 were heard, no murmur. The apex beat was at the left fifth intercostal space medial to the mid-clavicular line. And on per abdomen examination, it was soft, non-tender, and no organomegaly. This is a video of the muscle twitching of the patient. So here we can appreciate the undulating myokymia present in the calf muscle of the patient. It is appreciated in both the limbs. Case summary. So a 25-year-old male from Mulsalavagi Taluk presented with complaints of abnormal muscle twitching and low back pain radiating to both the lower limbs, accompanied by numbness, tingling sensations, and painful cramps. He also reported significantly reduced sleep, averaging 2 to 3 hours per night, and on examination, fasciculations were observed in both the calf muscles. The differential diagnosis was Morvan syndrome, motor neuron disease, Isaac syndrome, and polymyositis. The investigations that were done were routine blood investigations such as complete blood count where everything was normal. CRP and ESR was also within the normal range, and there was no abnormalities in the renal profile. Thyroid profile also showed no abnormalities, and the HIV rapid antibodies 1 and 2 were negative. HBsAg spot test was negative, HCV spot test was negative, and VDRL test was non-reactive. Coagulation profile also showed no abnormalities, and body fluids were taken for malignancy, and the CSF quantity that was taken was 0.5 ml. On macroscopy, a clear colorless fluid was seen, and on microscopy, smears studied showed scant cellularity comprised of singly scattered lymphocytes in a clear background, and the impression was that it was negative for malignancy. Other investigations that were done were the MRI contrast of brain and spine, and no abnormalities were seen. The CECT of thorax, where no evidence of thymoma was seen. CT of abdomen and pelvis, where there were no abnormalities. Paraneoplastic antineuronal antibodies was negative. The serum anti-Caspar and LGI1 was strongly positive, and the CSF autoencephalitis panel report is still awaiting. The management that was given to the patient was pulse methylprednisolone, tablet oxcarbazepine, tablet azathioprine, tablet Encurate Chrono, tablet Petril MD, tablet Ativan 1 mg, tablet Itoshine MR, tablet mycophenolic acid 500 mg, tablet Ultracet Semi, and tablet Visolone. So the final diagnosis is, based on the patient's history of severe insomnia suggesting central nervous system dysfunction, labile blood pressure indicating autonomic dysfunction, and the presence of neuromyotonia with painful cramps pointing to peripheral neuropathy. The findings are indicative of Morvan syndrome. So what exactly is Morvan syndrome? In 1890, a French physician, Augustin Marie Morvan, first described a disease known now as Morvan syndrome. It was characterized by autonomic dysfunction and severe insomnia. To date, around 60 cases have been reported in the English literature. Morvan syndrome is a rare autoimmune neurological disorder caused by autoantibodies against the voltage-gated potassium channel proteins Caspr2 and LGI1, leading to the hyperactivity of central, autonomic, and peripheral nervous system, which manifests as myokymia, neuromyotonia, stiffness, autonomic nervous dysfunction, severe insomnia, and encephalopathy. Different combinations of LGI1 and Caspr2 antibodies in Morvan syndrome lead to diverse clinical presentations due to their distinct distribution. LGI1 is mainly found in central and peripheral nervous systems and affects the synaptic transmission and increases neuronal excitability, while Caspr neoplasms respond well to immunotherapy, which is the primary goal for a patient. That's all.
Okay, any questions from the audience?
So,
Being a laboratory person, I want to tell you, you should write every investigation report with units. Okay, you are
Yes,
not
ma'am.
mentioned any units. And what was the TFT report?
Ma'am.
TSH is 0.1. So is it normal? Go back to
yes, ma'am.
the investigation reports.
Yes, ma'am.
What is normal TSH?
No, ma'am.
And something which is not very significant, you do not put the details of that, like that CSF for malignancy. You can just tell that it was negative for malignancy.
Okay, ma'am.
And rather than malignancy, what is important here is the meningitis features were not there.
Yes,
So you can tell that it was negative for inflammation. Okay.
yes, ma'am.
So that is more important than whatever you are saying. And units everywhere.
Okay, ma'am.
So you're not supposed to reveal patient.
Yes, sir.
That is because again, like we need to take the undertaking, right?
Yes, sir. Thank you, ma'am.
Hello, yeah. What is Patil MD?
So Petrol MD is a benzodiazepine. It is the company name is Petrol MD, but the chemical is lorazepam.
Is it mouth dissolving?
Sir?
Mouth dissolving, MD is? Okay. See, I'll tell you some correction in your slide. Most of the slides you are telling no, 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 no. Okay?
Yes.
Don't focus on the no negative histories. Go with the positive history and attach those positive history with the next slides.
Yes, sir.
In discussion portion, lot of things you are reading it out, make it points,
Okay,
and then compile it down. Okay?
sir.
Okay.
Thank you, sir.
Next, at slot number 4, we have Tejas Reddy and Puneet BS from 4th year.
Good afternoon, everyone. Good afternoon, everyone. Myself, Punit BS, and here my friend Tejas. We both are presenting persistent Mullerian duct syndrome with inguinal hernia. Case details: 63-year-old male presenting complaint swelling in the left inguinoscrotal region for 8 years with recent onset of pain in the swelling over the past year. Relevant history: known history of left-sided cryptorchism since birth, left testis not palpable since birth, no children and impaired sexual function, no history of trauma, weightlifting or chronic cough. Chief complaints are swelling in the left inguinoscrotal region for 8 years, recent onset of pain in the swelling for the past year. History of presenting illness: a 63-year-old male presented with an insidious onset swelling in the left inguinoscrotal region which began 8 years ago and progressively enlarged from 2 into 2 cm to 20 into 15 cm. Initially the swelling was partially reducible but has become non-reducible since 1 year. The patient developed a dragging type of pain associated with the swelling which worsens with standing and physical exertion but is relieved by the rest. There is no history of trauma, weightlifting or chronic cough, constipation or blood in stools. Both testes have been not palpable since birth. Past history: no history of similar inguinoscrotal swelling or related symptoms. Bilateral cryptorchism present since birth. No prior surgical interventions. No relevant previous surgeries. Not on any regular medications. Trauma and lifestyle: no history of trauma, weightlifting or heavy lift or chronic cough. No gastrointestinal issues such as constipation or bleeding. General physical examination: notable solitary irregular pear-shaped swelling of a size 20 into 15 cm extending from the left inguinal region to the base of the scrotum. Loss of scrotal range and presence of dilated veins. Penis position between the swelling and the opposite hemiscrotum not visible externally. This is the picture of solitary swelling and dilated veins. Palpation: swelling was non-tender with no evidence of a local rise in temperature or erythema. Swelling of variable consistency ranging from firm to elastic. Swelling non-reducible, no ability to palpate above the swelling. No inguinal lymphadenopathy detected. The left testis was not palpable, consistent with the prior history of cryptorchism. General physical examination: on auscultation, peristaltic sounds audible over the swelling, suggesting below bowel movement. Cough impulse test, Siemens test, deep ring occlusion test and invagination test could not be performed due to the size and nature of the swelling.
So the systemic examination, in CVS S1 and S2, both the heart sounds were heard and there were no murmurs. And RS, bilateral air entry was present and there was no abdominal distension. Abdomen was soft and non-tender and there was no hepatosplenomegaly. So the surgery done was, the procedure was a mesh hernioplasty with excision of rudimentary uterus and atrophied testis. So an incision of 4 to 5 centimeter was made in the left inguinal region and the hernial sac contents, it contained small intestine, a rudimentary uterus with atrophied ovaries and rudimentary fallopian tube. The intestine was reduced and the uterus and ovaries were excised. The posterior wall was repaired by proline sutures and a mesh was placed which was 7 into 15 centimeters mesh and the pubic tubercle was secured. The external oblique layer was closed with proline sutures. Subcutaneous layer was closed with vicryl sutures and the skin was closed with standard sutures. And the patient was told post-operatively to avoid oral intake and until further notice, and this scrotal support was provided. So this was the excised rudimentary uterus, fallopian tubes and the 2 testes. So the investigations done, they were ultrasound of the USG of the scrotum. It revealed a defect in the posterior wall of the inguinal canal with bowel herniation, complete distortion of the testis, and there were multiple calcifications. The histopathological report showed the uterus was found to be rudimentary with both endocervical and endometrial canals without malignancy. The ovaries were atrophied, they were mimicking ovaries, but they were testes with seminiferous tubules and ready testes and all that, exhibiting extensive fibrosis and absent spermatogenesis. The fallopian tubes were also rudimentary. The hernial sac showed chronic non-specific inflammation. And karyotyping showed 46XY, which was a normal male, but he had rudimentary uterus fallopian tube and all. So case summary, a 63-year-old male presented with an 8-year history of swelling in the left inguinal scrotal region, recently associated with pain since 1 year, and examination revealed a solitary large non-reducible scrotal swelling and with no local rise of temperature. Ultrasound showed a defect in the posterior wall of the inguinal canal with herniation of bowel, distortion of testis. Histopathological findings confirmed a rudimentary uterus with endocervical and endometrial canals, atrophied termination of the hernial sac. The patient underwent mesh hernioplasty, posterior wall repair, and excision of the rudimentary uterus and atrophied testis. So differential diagnosis, left-sided irreducible inguinal hernia with enterocele, was one, and Pantaloon's hernia. Pantaloon's hernia it involves both direct and inguinal hernia features. So the final diagnosis was persistent Mullerian duct syndrome presenting as a left-sided inguinal hernia. So topic discussion. Persistent Mullerian duct syndrome is a rare genetic disorder characterized by persistence of Mullerian ducts, which should normally regress in males due to anti-Mullerian hormone. This results in the presence of female reproductive structures in a genetically male individual. So Mullerian ducts, during embryonic development, Mullerian ducts develop into female reproductive organs like uterus, fallopian tubes, upper vagina, cervix and all. And if they do not regress, in normal male development, anti-Mullerian hormone causes these ducts to regress, leading to male reproductive structures from Wolffian ducts. And clinical presentation, it often presents with inguinal hernia containing ectopic female reproductive organs. The hernia contained a rudimentary uterus.
Yeah, stop your presentation. Reduce your slide and contents, right? Okay, open for discussion.
This one.
Yeah. Madam is asking to explain the picture. So it is better that you mark this picture before your presentation.
So can you make out here where is uterus, where is fallopian tube, where is testis?
उधर जाओ.
You can press Control P there. Control L. Control L. You exit from the slideshow. Huh. So you mark this. Could you make out what is what here before histopathology?
These were the atrophied testes, ma'am.
Okay, where is uterus?
Here are the fallopian tubes, I think.
You cannot think. You have to be sure when you're presenting.
Yeah, sorry.
And the order of presentation, your investigations are coming after histopathology, after surgery. USG you have put after surgery. It has to be before surgery. So you have to go in flow. Okay. So how the patient presented, what happened next, in same order you have to put your details also of the patient. Okay. First your USG will come and then the surgery, then the repair was done and the histopathology. In summary also the same way. Summary also it is jumbled up.
And I feel you need not repeat that case summary, okay, because you have 7 minutes. So don't repeat the case summary. Make sure that your presentation should be in flow, as madam said, right?
Yes, sir.
Okay. Yes. And favorite question, how do you do trans-illumination test?
It's done with an illuminoscope is taken and it is, we put a torch to...
You meet me tomorrow. Okay, chalo. Next.
Thank you, sir.
Next on slot number 5, we have Vinanti Vijayanayak from 4th year.
Excuse me, anyone from 2023 batch is here? Apart from presenters? No one has come. Whole batch is absent, sir. Yes, sir. Only the presenters are there, sir. Only 3 of them.
Good afternoon, everyone, respected dignitaries, judges, and my dear friends. Myself Vinanti Vijay Nayak, and now I'll be presenting a case of Psoas abscess secondary to metastasis. A patient complains of pain abdomen and discharge from the wound over the left lower abdomen since 1 day. Patient presented to us with a pain abdomen and wound over the left lower quadrant of abdomen following accidental removal of pigtail catheter, which was inserted for drainage of left psoas abscess in outside hospital. Pain is moderate in intensity, dull aching, no aggravating or relieving factors. The wound is also associated with purulent discharge, copious in amount. Patient also gives history of fever on and off. No history of cough, no history of back pain, no history of recurrent loss of weight. Next, coming to past history, she had undergone tubectomy 25 years back. She is a known case of type 2 diabetic mellitus since 6 years. No history of TB, epilepsy, asthma or hypertension. Next, coming to personal history, her diet was mixed, appetite was normal, sleep is adequate, bowel and bladder was normal and regular with no habits. There is no significant family history. Obstetric history is as follows. She attained menarche at around 14 years of age. Her obstetric score was P8L8 and she attained menopause 18 years ago. Next, coming to general physical examination. A 60-year-old female, moderately built, moderately nourished, well oriented to time, place and person. Her vitals are as follows. Pulse rate 98 beats per minute, BP 110 by 80 mmHg. Respiratory rate was 17 cycles per minute and she was afebrile. Pallor was present. There was no signs of icterus, cyanosis, clubbing, edema, generalized lymphadenopathy. Next we'll go to systemic examination, that is per abdominal examination. On inspection, abdomen is distended, umbilicus is central and inverted. All quadrants of the abdomen move equally with inspiration. Purulent discharging sinus is present over the left lower quadrant, copious in amount. There was no visible mass or engorged vein or visible pulsation or peristalsis. Hernial orifice appears to be normal. Flanks are not full and external genitalia appears to be normal. On palpation, there is no local rise of temperature. Abdomen is soft and severe tenderness is present all over the abdomen. Localized guarding present in the left lower quadrant. There is no palpable mass. No tenderness present over the renal angle. On percussion, tympanic note present all over the abdomen. On auscultation, bubble sounds are present. Her respiratory system examination showed a bilateral normal vesicular breathing sound with no added sound. On CVS examination, S1, S2 heard with no murmurs. On CNS examination, she was conscious and oriented. So this is my differential diagnosis. They are primary Psoas abscess, Psoas abscess secondary to Pott's spine, Psoas abscess secondary to Crohn's disease, Psoas abscess secondary to recurrent UTI, Psoas abscess secondary to colorectal cancer. Next, coming to management, here are my investigations. First coming, her HB was below, that is 7.3 gram. Her eosinophil is increased and her ESR is raised. On Zn staining, acid-fast bacilli is not seen. On gram staining, gram-negative bacilli with pus cells are seen. Her serum ADA is normal. On USD of abdomen and pelvis, there was an organized abscess in left psoas region. When CECT abdomen and pelvis was done, there was a collection extending from lower part of the psoas muscle and mass in the left iliac fossa, eroding the left iliac bone and encasing but not infiltrating left iliac vessels. So these are the CT showing psoas muscle and mass in the left iliac region, and CT scan showing iliac bone erosion. USD guided FNAC was done, which shown mass suggesting features of suppurative inflammation. So my final diagnosis is Psoas abscess secondary to carcinoma cervix. So it was treated as follows. The patient was posted for drainage of the Psoas abscess. Intraoperatively 30 ml of purulent material was drained from the Psoas region and expulsion of whitish granular soft tissue material was noted from the pelvis, which was sent for histopathological examination and was reported as squamous cell carcinoma. So the patient was referred to higher center for chemotherapy, and these are the intraoperative image, and HPR report shows keratin pulses. Then the patient was referred to higher center for chemotherapy and radiotherapy. So I would conclude by saying that the presentation as a Psoas abscess with no history of primary lesion limited initial consideration of this case, so that a metastatic Psoas abscess, it is probable that early cytological assessment of the aspirated material should have been performed in this case to avoid delayed diagnosis. This case highlights that metastasis from squamous cell carcinoma of the cervix can present as an isolated Psoas abscess clinically and radiologically. This case demonstrates certain difficulties in diagnosis even with newer imaging modalities. High suspicion of metastasis with cytological evolution of the aspirated material should be performed before making diagnosis. These are my references. Thank you.
So what is her past history in this case? Is she giving any history of white discharge or fall?
No. She did not give any past history of white discharge or
Any
no ma'am, irregular menstruation also she did not give.
any abnormal uterine bleeding history
No,
is there? She has not taken any treatment.
Ma'am, no ma'am, but she had undergone tubectomy. That is, but not any significant past history like abnormal uterine bleeding or irregular menstruation, nothing like that.
What are the various histopathological types of carcinoma cervix? You told us cytology is important.
Yes.
What are various types of cells? Or
On squamous cell, if it is squamous cell carcinoma, then keratin pulse can be seen.
So how does CA cervix spreads? Because it is very rare to present as the Psoas abscess. How it spreads? It mainly lymphatic spread. It spreads to the lymphatics.
Do prepare all the slides. Okay. The second thing, your bullet sign is question mark. Go to your slides. That shows that it's a copy paste. No, definitely. Yeah. All are question marks. So it's for audience or for you? For the audience? No. Okay. So this is big error. Fine. And second thing, the image in the CT 3D, is it the same patients or different?
Same.
Are you sure? Because there is some change. It's the same patient?
Yes.
Okay. No, because don't take it from Google. It is showing little changes. Okay.
Not from Google, from the patient.
It's one patient. Okay, good. Chalo, next. Sorry. Please be on stage.
You go to your slide of final diagnosis. Before that, what was the previous slide? Previous slide. Show the previous slide. So USG was done, FNAC was done, CT scan was done. Then next, what is next? Directly final diagnosis was given on USG, CT scan. In your differential, there is nowhere Psoas abscess secondary to CA cervix. So how did you diagnose CA cervix? Without any clinical symptoms, no signs, nothing was there. So how this was diagnosed immediately, all of a sudden, secondary to CS cervix?
Ma'am, when she presented to us with abscess, then it was drained and there was a mass in the left iliac fossa. That mass was sent for biopsy. Biopsy, then we came to know that keratin pulse were present.
There were no keratin pearls in the biopsy.
And finding of keratin pearls, does it make it carcinoma cervix? Or it can be present in squamous cell carcinoma from any site? There are many missing links in this. Okay, cervical biopsy was also done to prove that origin is from cervix.
So you have to put here after CT scan, histopathology biopsy was taken and it was sent for histopathology, which showed as metastatic SCC and of unknown primary. So how the primary was traced then? What other investigations were done? That has to be put there. So biopsy was taken from cervix later. Before that, I think there was pars speculum examination, PV examination done, and there was some mass there. So all that has to be put. Okay, and that histopathology picture is, I don't think is of that same case. So Google pictures, I think will be, I don't know how they are going to catch it. So it is not from the same case.
Is it the same case? Yes. Sure, okay. So pray that you will not get pathologists in your room, okay, before presentation, fine? Chalo, see, they can catch you and you should defend yourself. It is a training program, so make sure that you have to defend. If at all, if somebody says that that's from Google, make sure that you have a geotag image with you, collect from the PGs and keep it ready for your safety things, right? Okay, thank you.
Next, at slot number 6, we have Varshini Badagandi from 4th year.
Good afternoon, everyone. First, I would like to start by wishing all the professors a very happy Teachers' Day. Here, I am Varshini Badagandi presenting to you a case, congenital parotid sialolipoma, which is the second case reported in the world. So, topics to be covered under this heading are introduction, case report, investigations, treatment, and lastly discussion. Coming to the introduction. Sialolipoma is a rare and a newly recognized distant salivary gland neoplasm which has an overall incidence of 0.3% of salivary gland tumors in adults. Grossly, it is characterized as a well-circumscribed, soft yellow mass. Histologically, it contains both mature adipose tissue as entrapped in the normal salivary glandular components, which is surrounded by the fibrous capsule. It was first described by Nago et al. There have been more than 30 cases of sialolipoma reported and reviewed. The majority of the cases have involved the parotid gland, but submandibular and minor salivary gland tumors have also been described. 90% of the reported cases occurred in adults older than 18 years of age. There have been 3 published cases in children less than 5 years with only a single congenital parotid tumor which was reported in US. So this is the second case reported in the world and first in India. Coming to the case report. A 14-month-old male child was admitted in surgery department for a left-sided facial swelling. The mother noticed the swelling soon after the birth, initially 2 into 2 cm in size, which was gradually increasing in size over the last 1 year but remained asymptomatic. His growth and development were otherwise normal. This is the picture of the patient. On examination, a soft, non-tender, mobile swelling measuring 10 into 8 cm in the parotid region, extending into the posterior region of the neck and to the cheek was present. Surface of the swelling was partly lobulated, smooth and slip sign was positive. No facial weakness was noted as such and no cervical lymphadenopathy was present. This is the picture of the swelling again. Coming to the investigations. So the routine investigations in this patient came to be normal. Coming to the radiological investigations, USG said it was a prominent soft tissue arising from the left parotid gland. FNEC suggests it was a benign tumor of the salivary gland. Under the MRI report, we got a left parotid mass which involved the parotid space which extended into the parapharyngeal space, submandibular space with septations, as we can see here. Coming to the treatment. The treatment of choice was total conservative parotidectomy with conservation of the facial nerve. Here are the intra-op pictures. We give a modified Blair incision with retraction of the skin. Here we can see the fatty tissue. We mobilize the gland and further identify the facial nerve. Here we can see the facial nerve and its branches. This is post-operative. Post-operative. Patient experienced mild lower left-sided facial weakness that resolved within 48 hours. Under the HPR report, it revealed benign salivary gland tissue which was intermixed with mature adipose tissue, lymph nodes and vessels which was surrounded by fibrous capsule. These are the HPR reports. Here, the pink tissue is the acini of the salivary gland, whereas the white part is the fatty tissue which is separated by the fibrous septa, which is also lymph nodes are present with blood vessels. Lastly, the discussion. Sialolipomas in the pediatric population are exceedingly rare. Similar case was described by Hornigold et al. The tumor involved the left parotid gland, increasingly noticed from birth until presentation, and was asymptomatic tumor involving only the superficial lobe. Imaging studies. Here MRI was very useful. Imaging is warranted in the workup of the salivary gland swelling in the pediatric population, given the rarity of the tumors compared to the more common cause of neck swelling such as infectious parotitis, cystic hygromas and branchial cleft cysts. Histopathology. HPR requires an adequate tissue sample to demonstrate a unique histological features of the tumor. The histological differential diagnosis of sialolipoma of salivary gland tumor are lipomatosis, lipoadenoma and pleomorphic adenoma. Coming to surgery, there have been no reported case of recurrence of sialolipoma after complete surgical excision. It has been mentioned that recurrence is seen in incomplete excision of sialolipoma. So preferred surgery here is total conservative parotidectomy. Take home message. This case describes a rare benign diagnosis that should be considered in the differential diagnosis of congenital parotid swellings. Definitive management requires complete surgical excision of the mass involved in the parotid lobes. These are my references. Thank you.
House is open for discussion.
What was the role of the frozen section here? Frozen section, is there any role?
Sir, yes sir. Frozen section would have helped sir, but here, sir, during the intra-op conditions, we can take a frozen section, check in the histopath reports if there is any malignancy as to excise how much excision should be done in the gland.
Okay. Was it been done in this case?
Yes sir, it was done.
Okay. Any questions? Next.
Now on slot number 7 we have Ayush Lokhande from second year.
A very good afternoon to the honorable member of the jury and all my dear friends. Just like assembling a puzzle, we need to carefully understand every clinical symptom, neurological symptom and dermatological finding and genetic clue. So let's delve into this case, the puzzle of tuberous sclerosis, a case of systemic surprises. So tuberous sclerosis is an autosomal dominant genetic disorder which is also known as epiloia. Epi stands for epilepsy, loia stands for low intelligence, and A stands for angiofibromas, with the prevalence ranging from 1 in 6,000 to 1 in 12,000. It happens because of genetic mutation in TSC1 and TSC2 genes, which encodes for protein hamartin and tuberin respectively. These proteins are tumor growth suppressor, which regulates cell proliferation and differentiation. The classical triad of TS is seizures, mental retardation, and angiofibromas, but these symptoms occur in only 29% of the patients. Moving forwards, we see in this case that there are different hamartomas, which are benign neoplasm in various organs, which includes brain, kidneys, lungs, heart, and skin. So moving to the case, so a 51-year-old male came to our hospital with chief complaints of lesion on face since 25 years, cough with expectoration since 1 month, and breathlessness since 1 month. So this is the case history. A 51-year-old male came to dermatology OPD in our college and presented with complaints of multiple asymptomatic hypopigmented papules, which are facial angiofibromas over the malar area, chin and back, which were growing since 25 years. He also had complaints of cough with expectoration and breathlessness for 1 month. On sputum examination, we saw that the sputum was whitish in color, scanty in amount, and mucoid in consistency. There was past medical history of application of topicals and oral medications, but the details were not known to the patient, and no other comorbidities were present as such. Coming to the personal history, we found that his diet was of mixed type, he slept adequately and had normal frequency of bowel and bladder movement. He was a known alcoholic since 20 years, but he had stopped 2 months back, and he was a known smoker and tobacco chewer. His family history revealed that his son had similar skin lesions. On examination, we found out that father was present and he had syndactyly of index finger and middle finger of right hand. Nails showed periungual fibroma, which is also known as Conant's tumor, over the right second, fourth, fifth and left toe. Here we can see facial angiofibromas and syndactyly, and we can also appreciate Conant's tumor, which is periungual fibroma, in the images shown. On physical examination, we saw multiple hypopigmented papules on face which were growing from 25 years, and hypopigmented macules. Ash leaf spot was seen on the back. The patient was conscious, moderately built, and he was hemodynamically stable. On systemic examination, we noted that he showed grade 3 breathlessness according to modified medical research counseling grading. And on oral examination, we found out that he had poor dental hygiene, and on cardiac and neurological examination revealed no abnormalities. He was sent in ophthalmology department for fundoscopy, but we did not see retinal hamartomas there. So a differential diagnosis was made of neurofibromatosis type 1, lymphangioliomyomatosis, von Hippel-Lindau syndrome, and hypomelanosis of Ito, given his skin lesions. So a provisional diagnosis, considering his examinatory and history findings, we thought that it was most likely a case of tuberous sclerosis complex, as he fulfilled the major criteria of it. So we did some investigations and we found out that his hemoglobin was severely low. So we sent the slide for peripheral smear, and we found that he had severe microcytic hypochromic anemia, and few normocytes were also seen. So he had dimorphic anemia. Folic acid level were less, and renal profile, urine profile and LFT were within the normal ranges. On radio diagnosis, we saw that the kidney show hyperechoic lesions. So an impression was made of angiomyolipomas or renal cell carcinoma, but renal cell carcinoma was very less likely in this condition. Also, we noted grade 3 fatty liver. Chest X-ray was taken and it was found to be normal. No pulmonary lymphangiomyomas were found. So a final diagnosis was made that a 51-year-old male with tuberous sclerosis complex showing angiomyolipoma, severe microcytic hypochromic anemia with reactionary thrombocytosis, facial angiofibroma and periungual fibroma. So the treatment for tuberous sclerosis is systemic management, symptomatic treatment and long-term care. So removal of facial angiofibroma by laser and topical rapamycin was given. Ferric carboxymaltose was given for severe anemia, and montelukast, tuberculin sulfate and bromhexin was given for cough, which was improved in the further course. So tuberous sclerosis typically show three clinical features, as I have said earlier. The walk triad, which includes mental retardation, epilepsy, and facial angiofibromas. However, our patient did not show any epileptic or low intelligence. So our patient fall into that category of normal intelligence. Cutaneous lesions in tuberous sclerosis are hypomelanotic macule, facial angiofibroma, and shagreen patch. The hypomelanotic macules are seen at the birth, and facial angiofibromas are seen during the preschool years, but our patient did not present it with like that, and there was a butterfly distribution. These are my references. Thank you.
You should not use case sheets. You have taken case sheet photos, no? You can write instead of findings in the slides.
Okay, ma'am.
Please use directly case sheets.
This is to defend yourself because there are other parameters also. So when you're presenting, make sure that you take one part of it.
Yes, sir.
Your concept is good, but other parameters if I enter into, then total your flow will be in other directions. You understand what I'm talking about? He's alcoholic, so I will more focus on LFT. You are more focusing on other parameters. You understand what I'm talking about? Huh? Okay.
Yes, sir. Thank you, sir. Thank you.
Anybody?
You are telling that this is not there. Why?
Sir, because in tuberous sclerosis there are...
Why you are suspecting tuberous sclerosis before exam, before conclusion only?
Sir, because he present, according to the diagnostic criteria for tuberous
Three times you told, during investigation also, during discussion also. You are telling this is not there, this is not there. Why you are telling this is not there?
Sir, because usually...
No, whatever it is there, you tell your diagnosis. Don't expect everything has to be there.
Yes, sir. Sir, it was just to rule out the other...
You rule out once you tell completely after discussion or whenever you are in conclusion. Whenever still you are in investigation, that time only you are excluding everything. Please don't exclude that one. That indicates you are having preoccupied mind. Already you are knowing diagnosis, you are excluding in investigation itself or in clinical examination itself only. Don't do that one.
Okay, sir.
Ayush, how big was the renal mass?
Sorry, ma'am?
How big was the renal mass?
Ma'am, it was bulky in size, 11 into 7.1 centimeter.
So what was done for that?
Ma'am, nothing was done actually.
And how could you say it is angiomyolipoma on
Ma'am,
imaging?
the impression from radiology department, the abdominal USG showed that it was angiomyolipoma because of the hyperechoic lesions. So it could either be renal cell carcinoma or angiomyolipoma. But renal cell carcinoma is very less likely in this condition given his other clinical features.
Why? It can be seen in tuberous sclerosis complex, no?
Ma'am, renal cell carcinoma,
So what should be the approach for that renal mass?
Sorry, ma'am?
What should be the approach for that renal mass? What should be done further?
Ma'am, a biopsy should be taken, renal biopsy, and then we can see if there is any risk of malignancy. But mostly if we are diagnosing it as tuberous sclerosis, then it is mostly benign hematomas.
It cannot be the final diagnosis, okay? Just on imaging. It is just telling that it is a renal mass.
Yes, ma'am, it is indicative of tuberous sclerosis. It is not like a final diagnostic criteria. Thank you.
Next, at slot number 8, we have Siddhi Kapale from 4th year.
Good afternoon to the respected jury and the lovely audience present here. Mothers always show concern about their daughters' periods. But what if their daughters don't get their periods, even when they reach puberty? Can you guys think of some cause? Well, through my case, you might get a hint of causes of primary amenorrhea. I'll be presenting a case of imperforate hymen, a rare case of congenital membranous obstruction. So 15 years old patient came to the BLDE hospital residing in Sangogi. She's a school student by occupation. Her chief complaints were acute lower abdominal pain since 2 days and difficulty in passing urine since 2 days. History of presenting illness. The patient was asymptomatic 2 days ago, after which she had an episode of severe acute abdominal pain, which was sudden in onset, non-specific in type, radiating to back and gradually progressive in nature. She also developed urinary retention, which was insidious in onset and gradually progressive in nature. There were no aggravating or relieving factors. She earlier visited a doctor at her local place for the same complaint of acute onset of urinary retention, where her urine was drained, and she was referred to our hospital. On examination, the patient presented with severe pain in lower abdomen for 7 to 8 hours before the admission. She visited our gynecology clinic for worsening pain. There was no history of trauma, no history of fever or burning maturation. Past history, she had no similar complaints in the past, and she is not a known case of hypertension, diabetes, asthma or other respiratory diseases. No history of previous surgeries or blood transfusions was found. Menstrual history, no menstruation was found. Obstetric history, nulliparous and non-married. Family history, no similar complaints were found in family. Personal history, diet was mixed, appetite was decreased, sleep was disturbed, bowel and bladder, regular bowel and urinary retention with bulged bladder per abdomen was found. Examination findings. The general physical examination revealed the patient is moderately built, moderately nourished, conscious and cooperative and well oriented to time, place and person. No signs of pallor, icterus, clubbing, cyanosis, cholionicia, lymphadenopathy or edema were seen. Her vitals were BP was 122 by 90 mmHg, pulse rate was 94 beats per minute, she was a little tachycardiac, respiratory rate was 18 cycles per minute, temperature was febrile. Systemic examination revealed CVS, S1 and S2 were heard, no murmurs were heard. Respiratory system, bilateral air entry was present, normal vesicular breath sounds were heard. CNS, no focal neurological deficit. Per abdomen was found to be firm, tender and tensed. On local examination, there was bluish bulge per vaginum on vulvar examination and perineal bulge was also noted. There was suprapubic swelling seen per abdominal. So my provisional diagnosis would be imperforate hymen, transverse vaginal septum, vaginal atresia, vestibular cyst or vaginal abscess. We did investigations for the same, where hemoglobin was 12 grams per deciliter, blood grouping was A positive, platelet counts were 1,50,000 per microliters of blood, retroviral diseases negative, HbS Ag negative. On abdominal ultrasonography, a 13 into 15 centimeter hematocolapse and 9 into 6 centimeter hematometra was found. A final diagnosis, a nulliparous woman, 15 years old, was diagnosed with an imperforate hymen with hematometrocolpos. Treatment was under regional anesthesia. The patient was posted for hymenectomy. It was performed by giving a 0.5 centimeter cruciate incision and approximately 1 liter of dark colored tarry menstrual blood was drained. Foley's bulb was placed in situ and insufflated by 30 ml saline, which was done to prevent the reformation of the hymen after surgery. Then IV fluids, IV antibiotics and analgesics were given. Case was discharged without any complaints on post-operative day 3 and is advised to come for follow-up after 15 days. There was counseling of patient's parents also done. This is a video of the surgical procedure of cruciate hymen incision. So moving on to the discussion, an imperforate hymen is a congenital disorder where a hymen without an opening completely obstructs the vagina. It is caused by failure of the hymen to perforate during fetal development and is most often diagnosed in adolescent girls when menstrual blood accumulates in the vagina. It can be diagnosed late in adolescence, which makes it a rare case of congenital membranous obstruction. It is treated by surgical incision of hymen, which can be annular type or cruciate type. Imperforate hymen is very rare because its incidence is 0.1 to 0.05% at birth per like 1 in 1000 births. So these symptoms are recorded in 58% of patients with hematocolpos, like the complaints of pain, sudden need to urinate, and blood accumulated in vagina. It can be associated with complications such as cryptomenorrhea, amenorrhea, urinary retention, UTI, hydronephrosis, endometriosis, intrauterine or vaginal adhesions, pelvic infections, like that. So these are my references. Thank you.
What are other causes of primary amenorrhea?
Ma'am, there can be vaginal atresia, vaginal agenesis, other Mullerian duct deformities like bicornuate uterus and like septate uterus which is obstructing, septate vaginal anomalies, transverse septum vaginal anomalies, and imperforate hymen.
Other bicornuate and septate uterus will not cause amenorrhea. No? She will have menses, but she may have dysmenorrhea in those cases.
Primary amenorrhea, you can have the obstruction of the vaginal opening so that there is cryptoamenorrhea. So it can be also due to Gardner's cyst and vaginal abscess which is obstructing the vaginal outflow. And there might be gonadal agenesis, and from that estrogen and progesterone not secreted, and then cycles.
Which syndrome gonadal agenesis is associated?
MRKH syndrome, there is other systems also, syndromes like Fraser's syndrome and all, which can
What is
be.
Turner syndrome? What do you mean by Turner's?
Ma'am, the 45x0 presentation of the phenotypically female and genotypic it's 45x0. So in that there is no gonadal production of hormones, and therefore they can't have menses and proper secondary sexual functions.
Okay, there are some suggestions. One, remove the name of the patient.
Yes, sir.
Second, you are reading the whole case sheet, which I also don't expect, and people get bored. I said you, I'll repeat only the positive facts in your paper.
Okay, sir.
Third, if you don't have, do you have any other image other than the videos?
No, sir, because the patient went and she is yet to come for follow-up.
No, I don't want to listen to any right now, okay?
Okay, sir.
We can't say there also, but try to find out if there are any images, ultrasound image or else the procedure, the catheterization image, right? If
Yes,
you
sir,
do
yes.
have, put them.
Yes, ma'am.
Only the image is there in procedure. Then this video, don't wait, you have to run it. Because there is no second step other than draining it, okay?
Okay,
So
sir.
this is the way how we have drained, and just move on.
Okay,
Fine?
sir. Okay.
Don't allow them to see again and find out some questions out of those videos, right?
Okay, sir.
Sure, thank you.
Thank you, sir.
Now on slot number 9, we have Bhagyashri Nimbal from 2019 batch.
Good afternoon, everybody. This is Bhagyashri. Today I'll be presenting on my topic, that is inguinal hernia containing urinary bladder and calculus, a case report. So in my presentation, I'll cover the review of the pathophysiology of inguinal hernias involving the bladder, discuss the clinical presentation and common symptoms of inguinal bladder hernia, to emphasize importance of history and clinical examination in the diagnosis of inguinal bladder hernias, and to outline the management options including surgical interventions for treating inguinal bladder hernias. So coming to introduction, inguinal hernias with urinary bladder herniation are rare. They are often difficult to diagnose and remain a surgical challenge. Preoperative diagnosis is essential to prevent iatrogenic injury. We report a case of inguinal bladder hernia with calculus which was diagnosed intraoperatively. So coming to case presentation, a 60-year-old male farmer by occupation came with complaints of swelling in left inguinoscaudal region since 1 year. History of presenting illness, he complains of swelling in the left groin region since 1 year, extending until the base of the scrotum. The swelling was insidious in onset, gradually progressive from a size of approximately 2 into 2 centimeter to a size of approximately 8 into 6 centimeters. It aggravates with standing and coughing. It relieved partially on lying down. It was irreducible. The swelling was associated with a dragging type of pain which was aggravated with standing. He also gave a history of burning sensation and dribbling of urine with history of difficulty in passing urine for 4 days. There were no symptoms of suggestive of obstruction or strangulation, no history of trauma or no history of fever. He gave history of tobacco chewing since 30 years and alcohol intake since 30 years and claims to have stopped alcohol intake since 6 years. No significant family history was given. On general examination, a middle-aged gentleman appears to be moderately built and nourished and well-oriented. His vitals were within normal range. On local examination, that is examination of inguinoscaudal region, the patient was examined in supine and standing position under natural light. On inspection, a swelling was noted in left inguinal region extending till scrotum and descent till base of the scrotum. Scrotal rugae was partially lost and no other skin changes were noted. No visible pulsations were seen. Penis was central and normal. Cough impulse was positive. On palpation, all inspectory findings were confirmed. A solitary irregular swelling of size 8 into 6 centimeter extending from inguinal region until the base of scrotum was palpable. The swelling was non-tender and no local rise of temperature was felt. The swelling was of variable consistency ranging in between firm to hard. The swelling was not reducible. We couldn't get above the swelling. Both testes were palpable. Cough impulse was positive. Trans-illumination test was negative and ring invagination test was negative. No inguinal lymphadenopathy was felt. On parectal examination, no prostatomegaly was felt and his systemic examination was normally functioning. We came to a provisional diagnosis of left-sided irreducible complete inguinal hernia. We also had other differentials in mind, that is Pantolins hernia of left side and sliding hernia. So investigations were done where preoperative USG was sent. Preoperative USG of left inguinoscaudal region was sent and hernia was seen which showed hernial sac with fat fluid and 31 millimeter size of calculus. Right side, no inguinal hernia was seen. It didn't clearly show that contents of hernia were urinary bladder. So final diagnosis, left side diet hernia, sliding hernia with bladder as content with vesical calculus. During intraoperative, the patient underwent surgical exploration of inguinoscaudal region when they realized the contents of hernia were urinary bladder with a stone. Excision of the cystolithiasis was done through trans-inguinal cystostomy, followed by bladder repair with hernioplasty and posterior wall repair by Bassanese method. So these are the intraoperative images showing calculus and urinary bladder with catheterization. So the specimen was sent for histopathological examination. One big stone, yellowish brown gritty, measuring about 6 into 5 centimeter. That is stone from urinary bladder. And a section study showed tissue lined by transitional epithelium. This confirmed the content of hernia was urinary bladder. So after surgery, the patient had no complications post-operatively and was discharged with catheter in situ. After 3 weeks, catheter was removed. So coming to discussion, bladder involvement in inguinal hernia is very rare, occurring in approximately 1 to 4% of the inguinal hernias. Etiopathologically, it may be related to bladder outlet obstruction, with chronically distended bladder with a decreased bladder tone and weakness of pelvic floor muscles in combination with weakness of abdominal and bladder wall will be involved. Bladder can slide through dilated inguinal ring. So what symptoms can patient come with? Majority of patients with bladder hernias are asymptomatic and diagnosis is made intraoperatively. Swelling in the groin or scrotum, urinary retention and lower urinary tract symptoms, dual voiding, size reduction of scrotal after voiding suggests the presence of the bladder in the hernia sac. In literature it was called Mary's sign. Calculi are most likely the result of urinary stresses in the herniated portion of the bladder. Diagnosis can be done by ultrasound if done with high index of suspicion. It can show hyperechogenic mass lesion protruding from bladder into scrotum. However, sometimes it can be difficult to identify the contents by ultrasound. So if bladder hernia is suspected, voiding cystourethropy can be done. It shows dog ear shaped bladder. Management surgery is best option. Open surgical technique is preferred over laparoscopic. Treatment is typically by open inguinal hernia repair with manual bladder reduction, but this method also poses risk of iatrogenic injury to the bladder. If stone is present in the bladder, then cystostomy is done to remove the stone and then bladder wall is repaired. Patients may opt for conservative therapy such as watchful waiting or intermittent catheterization. So these are the learning points. These are my references. Thank you.
Yeah, very good evening. See, hernia means it is you are giving bread to everybody to ask questions. So be perfect in your anatomy and other things. One thing, add image to all your slides. The second thing, it's very interesting topic. So they'll bombard you with questions.
Yes.
The simple question that I'm asking you is, did you check the tone of the muscle?
Sorry, sir.
Tone of the muscle. Which test did you do?
We do like leg rising tests.
So what do you see?
So,
Okay, let's go with a rapid round now. Fine. Did you palpate urethra?
no, sir, like we could not.
Where you palpate urethra? In clinical examination.
Urethra we cannot. Like per rectal examination, while doing we check for prostatomegaly and we can also palpate urethra.
Okay, auscultation did you do in this patient over the swelling?
No, sir.
No, you don't have auscultation finding. No. Why it was missed? No, you are saying bladder as a content?
Yes, sir.
Yeah. Okay, fluctuation test?
Fluctuation test was done, sir.
Finding?
And
Findings? Okay,
so
what does the image of the surgery show there? There is a bladder coming out.
Yes.
So what does it indicate?
So like a part of bladder was out, sir, and like.
No, in the surgery the bladder was cut.
It was cut, sir, and stone was removed from bladder.
Okay.
Then it was.
How the stone was identified on table? Because it's my unit case, so I'm asking you. Don't think that I'm asking you here because in other audience.
The stone was not found before like operation, like before surgery. So it was by chance found in.
By chance, nahi. वो तुम्हारा word है, हाँ.
Intraoperatively, it was found, sir. So they did cystostomy. Like they removed the bladder, stone. Then
Okay, be particular about the surgery there, okay? So what they did, what all things they did, and how they did. You understood? You catch hold of the staff, understand, and that they will ask you that these are the questions they'll throw you in. Okay? So thank you.
thank you, sir.
A very good day to all my fellow batchmates, judges, and my guide. So this is my case presentation, and I take this wonderful opportunity to present this rare case of a basal ganglia infarct in a 2-year-old child. So let's start with introduction. That is, traumatic basal ganglia infarcts are rare in pediatric patients. Their incidence is not described worldwide because of the rarity of the case and lack of data and research on the same. The basal ganglia as a structure is very crucial for motor control, cognition, and coordination, and it is susceptible to both ischemic and traumatic injuries. But normally we see that more commonly in adults, and very rare is a case of traumatic infarct seen in a pediatric case. If we go with case details, my patient is a 2-year-old male child, and the informant for this case is the child's mother. So it's reliable and honest information. On the chief complaints, the patient, our child was brought to by his mother to emergency department for the complaints of making hand gestures and movements predominantly from the right hand and foot. He was limping while walking, and he was unable to hold objects from the left hand. So his grip was affected, his walking was affected, and his Glasgow scale, when measured in the emergency department, was 15/15. But the power of the left side was 3/5. And then he was referred to neurosurgery for further investigations on the same. When we go to history of presenting illness, our patient, when his mother noticed it, that he was unable to walk properly, and he was preferring to sit. This is a highly active child who is now preferring to sit. And also he was playing only with one side, and he wasn't talking much. Then his mother gave us this history of his trivial fall from bed, which was 2 days back. And the patient was not brought immediately to the OPD because the mother assumed that he was having pain on his left hand side, and that's why he wasn't moving that side much. It wasn't associated to be any other disease or any other problem. He has no history of abnormal movements. There's no loss of vision, impaired hearing. There's no deviation of angle of mouth. There's no drooling of saliva. There's no impaired sensation of smell. No history of loss of consciousness is reported, and there's no history of recent infections, allergies, anything in the past. In past history, the child is very healthy, very fit, with no surgery, no blood transfusion, no infection, no allergies, no previous history of NICU admission. He's a 38 weeks baby, so he is not a preterm. And in family history, there is no similar complaints of any congenital disorders or BP, diabetes. There is nothing reported in the family. And he was born to a healthy 26-year-old mother, and he's a G3, he's the third born male child, and he's received his TT, iron, folic acid, calcium supplements, and his postnatal care has also been uneventful. There is nothing that is reported that could give us a diagnosis of something else or any other differentials. Developmental history, he's appropriate for age. He's well developed for his age. Immunization history is immunized up to date according to our national immunization schedule. His diet history is he started on complementary feeding since 5 months of age. Normally it's 6 months, but the mother had 3 children, so he was given earlier complementary feed. And his socio-economic status is Kupuswamy scale class 3, which is lower middle class. In general examination, all the vitals are normal when checked, and his systemic examination, cardiovascular system, S1, S2 present, there is no murmurs. Respiratory, there is bilateral air entry present. A gastroenteral system, there is soft and non-tender. In nervous system examination, GCS is 15/15. Child is alert, conscious, playful, he obeys our command. He is able to understand, and he occasionally talks and cries. In cranial nerve, we couldn't assess the first cranial nerve because of olfactory. We can't explain it to the child. On 2, we can see that he recognizes his parents, and he recognizes strangers as well. His pupil is round, regular, and reactive. His cranial nerve 3, 4, 5, 6 pupillary reflexes are present. There is full range of movements that is reported in extraocular movements. Cranial nerve 5 is also intact, both sensory and motor functions. Corneal reflex is also present. In cranial nerve 7, you see he gives facial expressions, he responds to us. His cranial nerve 8 is normal because he responds to stimuli, and he responds to the hear of sounds, and he looks around when he hears sound. 9, 10, and 11 we see because he eats food normally and regularly, and he chews. And cranial nerve 12 is also normal. But on the tone, when we observe the tone of our child, he sees that on the left side we see hypotonia, whereas on the right side it's completely normal range of movement. But on the left side we report hypotonia in both the upper limb as well as the lower limb. In power, we see the right hand side is a complete 5 on 5. He's active, he can move against gravity. But in upper limb and lower limb, it is 3 on 5, which is decreased. And in cerebral examinations, we don't see any signs of cerebral signs, overshooting, ataxia, gait. He could not walk on admission, probably because of the pain or hemiparesis. But skull and spine appear to be normal. Reflexes, we see sluggish reflexes on the left hand side. In coordination, we couldn't elicit because our child wasn't cooperative at that time. Sensory system is not as clearly understood in adults because it's pediatric, but we see he's cooperative and is conscious to our approach, and he's responding well to us. In investigations, this is very important that our CT is exactly normal. It has no hemorrhagic bleeds. There is nothing. You can see it's a stellar clear CT scan. But on MRI, you can see that infarct that is present, which shows basically a right capsular ganglionic region. You can see an infarct, which is located in the basal region, and it is a diffusion weighted sequence. When we carry on with the routine investigations to rule out any other metabolic causes, it's completely normal. So our diagnosis goes toward functional left-sided hemiparesis with no cranial nerve, sensory or cerebral involvement. In differentials, we have shaken baby syndrome, arteriovenous malformations, myoma disease. But our approach to this patient was conservative because of his age. It was anti-epileptic drugs and neurotropic drugs. In follow-up, we followed him up for 6 weeks, and he regained complete motor function along with physiotherapy. So our conclusion is this is a very rare case, and especially in children. So we can attribute it to the hypothesis that because of the peculiarities that are there in deep peripheral vessels in the brain of the children, this could be a cause because of that he developed this stroke. But we have to rule out all the other causes. And these are my guides, and these are my references. Thank you.
So open to audience. Priyanshi, no images, no videos.
So the parents of the child are not very comfortable with him, with us taking his photos or videos because they believe in nazar.
This I will think that as, what is black curtain?
Sorry, sir.
Black curtain?
Yeah,
No, I will not agree what you are saying. You can mask everything and you can show.
I'll get it.
See, without I'm not talking in a BLD, okay, I am with you. But when you go to the public audience, they have to see certain progress in what you have done, either in the form of image or in the form of video. Especially when it is a neuronal case, everybody expects a video to be there. You mask the face, no nothing. Even you can mask everything, only focus on the region which you want to show that there is improvement. Right?
Yes, I'll add it.
Sir, any questions?
So anti-epileptic drugs are used to avoid convulsions or basically we are avoiding a complication that the stroke can develop. So this is a conservative treatment. So we are trying to avoid it before he throws a seizure, he goes to a stage of complications. So yeah, it's a prophylactic.
See, one advice I'll give you, the topic is excellent. You can ring the bell, but your slides are overcrowding. If there is a overcrowding, even I don't like to see the slides because I will not be able to follow you. So make 4 dots with sentence, explain them. Your accent is good, knowledge is good, but reading the slides will not help you. You understand? It comes in last moment when there is a competition, then definitely you will go low than the person who is presenting good. Right? Okay, good. Sure.
Now on slot number 11, we have Anirudh Chachudi from 3rd year.
Hello everyone. So I'm going to present on the topic chronic inflammatory demyelinating polyradiculopathy with motor neuron disease and Parkinsonism-like symptoms. So this seems like a very huge topic, but you'll see what is the condition of the patient in the next slides. So first let us understand what the condition is. So chronic inflammatory demyelinating polyradiculopathy is a form of autoimmune polyneuropathy. So it is a disorder of peripheral nerves and nerve roots causing limb weakness and sensory deficit. It could begin asymmetrically in the limbs or continue from a mild to moderate form of GBS, that is Guillain-Barré syndrome. Crude incidence rate is 0.3 per lakh and crude prevalence is 0.281 per lakh. Mostly seen in middle and old age people, but could occur in anyone. It has many variants. So what is the pathology behind this condition? So basically, any nerve and its fastness of conduction depends upon two things. One is the length of the axon and second is the resisting membrane. So the resisting membrane is a myelin sheath. Now sometimes what happens in autoimmune conditions, macrophage induced degeneration happens where they go and particularly select certain sites on the paranodal or nodal areas on the myelin sheath and go there and completely demyelinate the neuron. Because of that, what happens is the peripheral nerves cannot conduct and hence they will give rise to certain symptoms. The general symptoms what we see with CIPD, the CIDP, that is chronic inflammatory demyelinating polyneuropathy, is tingling, gradual weakening of muscles, loss of reflexes, loss of balance, and loss of feeling in the arms and legs. So hereby I'm presenting a case of a 34-year-old female patient. So she came with the complaints, chief complaints of difficulty in climbing stairs since 10 years, difficulty in gripping slippers since 8 years, recurrent falls since 8 years, and swaying while washing face since 6 years. History of presenting illness. A 36-year-old female patient presented with complaints of difficulty in climbing stairs and used to climb only with the help of supporting rails. Later, she also noticed difficulty in getting up after sitting. She could not get up, but only with the support of bystanders she could. She also complains of buckling in the knee. Buckling of the knee is nothing but when you're walking or when you're lifting something, your knees suddenly give up. Suddenly, you will stop feeling your knees. Following which she had frequent falls. She also gives a history of difficulty in gripping slippers and feels they will come off while she's walking. She also mentions about swaying while washing her face and hence takes support of the wash basin. She also gives history of left upper limb abnormal movements since 5 years, which was evident on lifting heavy weights, but now she also has tremors even on rest and has progressed to the right upper limb, insidious in onset and gradual in progression. There was no history of seizures, tingling or numbness, wasting or thinning of muscles, chest pain, fever, cough, visual disturbance or trauma. Now, by the history of presenting illness, they thought of cerebellar ataxia because, as well as Parkinsonism because she had rest tremors. But later on, when they got to know about her past history, which is history of hospitalization 20 years back because of multiple episodes of vomiting, known case of hyperacidity since 20 years and is on medication for the same, history of similar complaints and hospitalization 12 years back. There was also history of right ankle fracture 4 years back and known case of type 2 diabetes mellitus since diagnosed 1.5 years earlier and is on medication for the same. In her family history, her elder brother also has similar complaints. So we did a general physical examination whereby the patient is a middle-aged female, moderately built and nourished, conscious, oriented, comfortable and cooperative. Pulse rate was 80 beats, BP was 130 by 80, mmHg, temperature was afebrile and head-to-toe examination was all normal. We did the central nervous system examination where in her higher mental functions, in her speech she had a little bit of flaccid dysarthria, she had problems while speaking. Cranial nerves, orbicularis oculi was impaired on the right side. Rest all were normal. In the motor system, the bulk was normal, tone was normal, but in the lower limb there was hypotonia. Power, grade 4 power for all the muscles except again for her knees where there was grade 3 power. Gait, we could notice high stepping gait. In the sensory system, spinothalamic tract was normal, posterior column position sense was impaired, and cortical was normal. Also, systemic examination, CVS and RS were normal. Then, after, on the basis of history, we came with all of these differential diagnoses over here. In that, Guillain-Barré syndrome, multiple myeloma, Boehm syndrome, vitamin B12 deficiency, diabetic neuropathy, hereditary neuropathy, diabetic radiculopathy, peripheral nerve tremor, cerebellar ataxia, toxic neuropathy, motor neuron disease, and Friedreich ataxia. So, one thing which you'll notice over here is diagnosis of CIDP has been a challenge since years, but recently they gave out a criteria which was around 21 steps or 15 steps criteria, which involved various different conditions, and finally a standardized criteria for diagnosing CIDP was introduced. However, because of its vast variety of symptoms, it is still very difficult to rule out these differential diagnoses at the first sight. So in management, the investigations which are strongly advised for any case of CIDP are first of all electrodiagnosis, because electrodiagnosis basically measures the electric impulse conduction power between the nerves and the muscle. Fasting blood glucose because of diabetes, CBC, renal and liver, which is routine, and monoclonal protein detection because it's an autoimmune condition. Also, if indicated, that is in cases of certain peripheral nerve tumors, you need MRI, then CSF for protein elevation, which is a pathognomic of CIDP, and then CRP for any inflammation, nodal and paranodal antibodies because again it's autoimmune, and HIV serology. Treatment, corticosteroids, prednisolone, methylprednisolone, pulse therapy was given. Plasma exchange, plasmapheresis is indicated because of antibodies in the blood. Intravenous IVIG is the mainstay treatment. This is very helpful in any kind of autoimmune conditions. And monoclonal antibody therapy is also indicated but not done. Final diagnosis, chronic inflammatory demyelinating polyradiculopathy with suspected underlying motor neuron disease and Parkinsonism-like symptoms. Over here, we come to diagnosis of CIDP with the symptoms that she has, and it is a sensory predominant CIDP. CIDP has various variants in that she is under the sensory predominant CIDP with motor neuron disease because she has mild fasciculations, but it still has to be found out. Investigations are going on. And Parkinsonism-like symptoms because it is common with any long-standing case of CIDP. Thank you.
Open to audience.
No, my sincere suggestion to the juries, right? Before presentation, it has to pass through your committee or who is looking after. Every time, like you are saying, Deepak, that the slide is full of, and no, methodology has to be followed, right? Maybe at the beginning, I think.
No, I feel this is the first time they are presenting as a rehearsal undergraduate level.
Yes.
Yeah, what you said is suggestion is very well taken, sir. Yes. They need to present at the department level and correction to be made, and then they should be presenting here. But okay, there is no time, I feel so. So time was a big constraint. So okay, here also we can. So let's go by Indian style of correcting.
No, it has to be like if they are presenting. No, it has to be full-fledged.
Yeah, full-fledged. Yeah.
Yes.
I'm still repeating the things. All of you. This is, take these words whenever you are presenting any presentation anywhere. One is the logo, let it be your batch logo, let it be your university logo, let it be your college logo, right? The second thing, in the left corner, any corner you choose, your name in very small letters, right? Next, don't put any unrelated other images in your case presentations, right? And as usual, investigation, other things you are going to say. And here what you are doing is differential diagnosis, so many you have written, right? But I don't think so you have read all.
I've read some of
them. Some you have read, you add some. See, otherwise don't add everything. Because if I am more interested in knowing the thing which you don't know, right? Then you are at, तू अपना सिर दे रहा है, समझ ले मैं क्या बोल रहा हूँ? जो तूने पढ़ा है, you add that. Okay, that's smart way of getting out of the presentation, right? One. Second thing, your about investigations. Here you are taking our class, right? What you are talking in investigation is this investigation we are doing for this investigation we are doing for this. I am not interested to know. I am interested to know the results of the investigation that you have done. Understood?
Yes.
Take everything positively. Here we are not here to depress you or suppress you, right? Learning stage, take everything positively, the suggestions. Okay?
Yes.
And practice. I'm not joking. Practice within 6.5 minutes. In between stuck, thoda bahut upar niche, another 30 seconds are for you. Okay? If you go beyond your time, even though if you are very good, you will not get the results. It will not be in 1, 2, 3. You understand what I'm talking about?
Yes.
Right? Okay. Chalo.
Very good points by Dr. Deepak. But one thing I want to tell you, this is all a correcting session, that's all. Overcrowded slides are there. I am not pointing at you, all your friends I am telling. All are overcrowded slides. And I am finding all are reading the slides. Just reading the slides. That is not the way. This has to be curtailed. Actually, if you read the slides, nobody will like you. And only abnormal things on the investigation should be read. You are just reading HB so and so, TC so and so, that's not required actually. And methodology of PPT to be followed. It starts with chief complaints, history of present illness, clinical symptoms, then investigations. In that methodology it has to come. It is for everybody I am telling actually. And names and photos, there should not be any chance of identification of the patient. That is very, very this thing. It can be going for suing. And also one of the person had used the case sheet also. That is a very illegal actually. You should not take any Xerox or anything on the PPT. And subject knowledge has to be there when you are presenting some case or some article. Subject knowledge concerned topics should be read very properly. Otherwise, it is not possible. And one very good point by Deepak sir is that you should not cross the line. If you are crossing the time, they will make you go away from the whole competition. Next time, please correct all these things. Come with a good presentation, all of you. Okay? And another thing for all the audience, I am telling you, this is the last time you are going out of the auditorium back. And you are going and taking tea and you are chatting, you are using the mobile, and this way if you are doing, we are going to cancel the SRS wing. Last time I was not there, there was a very good feedback from the principal and others that you presented so nicely and I was very happy. And with that same hope I came here, and what I am seeing today I am not understanding. We took the attendance 3 times. Some people are going, some people are coming. Do you think this is some fair? We will not conduct. This is a torture for us. Okay.
Thank you, ma'am. Thank you, sir.
You said thank you for madam's words? No? Okay. Thank you.
Next, at slot number 12, we have Shri Sanjeev Teli from 3rd year.
Good evening, everyone. Myself, Shri Teli. My topic for today is pre-tremor phase of infantile tremor syndrome. Firstly, infantile tremor syndrome is a rare neurological disorder seen in infants and young children aged 6 months to 3 years. It is associated with nutritional deficiencies, particularly of vitamin B12. Most commonly seen in infants who are exclusively breastfed by mothers with poor nutrition that lack sufficient vitamin B12. The pre-tremor phase of infantile tremor syndrome is characterized by subtle earlier symptoms such as neuromotor regression, pallor, poor feeding, tremulous voice, and dull apathetic look, skin pigmentation, and many more. This often precedes the classic tremors associated with the condition. Identifying these early symptoms is crucially for timely intervention, as prompt diagnosis and treatment can significantly improve outcomes and prevent the progression to the more severe tremor phase of the syndrome. Case details. 10-month-old female from Khakanki, Bableshwar was brought to the pediatric department by her grandfather. Here, the child presented with the complaints of fever since 2 days and increased work of breathing since 2 days. The child was reportedly well until 2 days ago when she developed a fever which was sudden in onset, gradually progressive, intermittent type of fever, and was not associated with chills or rigor, and it was relieved with the medication. And there was one episode of uprolling of the eyes. This was not associated with any abnormal movements. Additionally, she has had increased work of breathing for the past 2 days and also presented with hyperpigmentation of dorsal aspects of hands, knees, and knuckles. Child also has history of developmental regression. Birth history. First, antenatal history. It is a registered case and mother has taken TT booster dose and iron folic acid supplements in second trimester. And it's a term pregnancy and undergone normal vaginal delivery, and child is cried immediately after the birth, and there is no NICU admission, and breastfeeding has done immediately after the birth. Family history. It is a secondary consanguineous marriage and mother was 23-year-old at time of conception. Child was second in order and first child is also female and is good in health. Developmental history. First, gross motor, fine motor, social milestones were attained to the age till 8 months. Since 2 months, developmental regression started. The developmental regressions, the patient's attender told us no progression in height and weight of the child after 8 months of age, and there is loss of motor skills like crawling and sitting independently, and there is decreased interest in social interactions, and there is diminished eye contact, and there is lack of response to familial faces. Immunization history. Child was immunized as per the schedule till date. General physical examination showed there is a presence of pallor and icterus, sinuses, clubbing, edema, lymphadenopathy, everything was absent. And as the child presented with the fever, there is temperature is elevated and heart rate and respiratory rate of the child is increased. And on anthropometric examination, we found out that the child's weight and height is reduced. So it suggests that the child is moderately malnourished. On systemic examination, it showed that there is an increased work of breathing with nasal flaring and mild intercostal retractions. There is a video of this. This is the video of the child with increased work of breathing. On cardiovascular examination, heart sounds and peripheral pulses, everything was normal. Neurological examination, the child was conscious and responsive with normal tone and movements. And the positive point in this is the hyperpigmentation of dorsal aspects of hands and knees and knuckles was present in this child. Differential diagnosis. Differential diagnosis are mainly these are respiratory infection and inborn error of metabolism. Why respiratory infection means, although infantile tremor syndrome and respiratory infection presents with non-specific early symptoms like poor feeding, fever, and increased work of breathing, infantile tremor syndrome is specifically linked to nutritional deficiencies like vitamin B12 and other micronutrients. But respiratory infection is caused by pathogens like viruses and bacteria. So it could not be the diagnosis for this condition. Then the second one is inborn error of metabolism. Here we have mentioned organic acidemia like methylmalonic acidemia. Why? It is because symptoms of methylmalonic acidemia and infantile tremor syndrome are very similar. But the thing is, Etiology of the infant tremor syndrome is still unclear, but etiology for the methylmalonic acidemia is it occurs because of the deficiency of methylmalonyl-CoA mutase, which leads to the methylmalonic acid accumulation in the blood and tissues, which causes neurological dysfunction. So in this management, CBC showed there is an indication of anemia in this patient, and everything was normal except there is a low serum vitamin B12 levels in both the child and his mother. Treatment, the child received comprehensive care and the doctor started with IV fluids first, and then they gave oxygen therapy, and again they administered IV antibiotics, and after that they started micronutrient supplementation, which includes vitamin B12 supplementation to both the mother and the baby. Baby came back for the doctor will see if her fever is gone, her breathing is normal, and her parents will know what warning signs to watch for, and her next visit will be in 1 to 2 weeks to ensure she is getting better or not. Case summaries, a 10-month-old child presented to the hospital with complaints of fever, as I told, with all the hyperpigmentation on the dorsal hand, neck, curl, and knees. Laboratory investigations, as I told, HB levels showed confirming of anemia, and the child was treated with IV fluids and all. So here the given clinical presentation of developmental regression, hyperpigmentation, anemia, and the maternal deficiency in vitamin B12, it is a diagnosis of infantile tremor syndrome. It's a discussion, and these are my references. Thank you.
Can you tell me what are the mistakes were in your slides and your presentation? Chalo. Out of the things, whatever we have said, what all mistakes you have done, so that what will you improve, you just tell us now.
Sir, I have to mention about all developmental history in this.
Developmental history, is it significant here?
Yes, sir.
Okay, good.
Because there is a developmental regression in this child.
Then don't take much time in family history then.
Okay.
Yeah, you are taking time more in unnecessary things, which I don't want to listen to. I want to listen to the positive facts and results. Right?
Okay.
I'll be more curious to know why she has brought that family diagram there. Got it? What I'm talking about? It's more highlighting to me. But I didn't find anything there, that I'll get disappointed.
Yes.
You understood?
Yes,
so don't, family history not significant enough. Okay, this move on to the second slide.
Yes.
Clear?
Yes, sir.
Okay, next.
Thank you, sir.
नहीं, और क्या क्या मिस्टेक है? यहाँ हम मार्क्स डाल रहे हैं, हमको टाइम पास चाहिए. Why overtime?
I took more time in explaining the differential diagnosis. So,
I know it's not a theory class, right?
yes, sir.
Okay, ma'am. Thank you.
Thank you.
I request everyone to please be seated while they tally the scores.
ಬರ್ತಾರಂತ್ರಿ ಮ್ಯಾಮ್ ರೂಮಲ್ಲಿ ಯು ಟಿಲ್ ದೆನ್ ಸ್ಪೀಕ್ ಅಬೌಟ್ ಅಟೆಂಡೆನ್ಸ್ ನೆಕ್ಸ್ಟ್ ರೌಂಡ್ ವಿ ಆರ್ ಮೇಕಿಂಗ್ ಬಯೋಮೆಟ್ರಿಕ್ಸ್ ನಾನೇ ಹೇಳ ಅಷ್ಟೇ ಏನಂತ ಹೇಳಿ ಮ್ಯಾಮ್ ದೇರ್ ವೆರಿ ಅಬ್ಸೆಂಟ್ ಟುಡೇಸ್ ಸ್ಟೂಡೆಂಟ್ಸ್ ಬಿಹೇವಿಯರ್ ಸೊ ಫ್ರಮ್ ನೆಕ್ಸ್ಟ್ ಟೈಮ್ ವಿ ಆರ್ ಮೇಕಿಂಗ್ ಬಯೋಮೆಟ್ರಿಕ್ಸ್ ಕಂಪಲ್ಸರಿ ಅಟ್ ದ ಎಂಡ್ ಆಫ್ ದ ಸೆಷನ್ ಅಂತ ಹೇಳ I think we are taking a plot of
video. You want this? Yeah. Right. Hello. One more. Hello, can you hear me?
Yes, sir. Yes, sir. Yes, sir. Good evening, sir. Good evening, sir. Sir? Sir, good evening, sir.
Good evening. Can you hear me?
Yeah, we can hear, sir.
Yeah,
So we have come to tallying.
All the teachers who are there.
Yeah.
Second, I would congratulate all the presenters. From Delhi, I saw all the presenters doing wonderfully, very well. And I'm sure you were tensed that with such a short notice how to do, but you have done well. You got a platform to correct, and I'm very happy that you people did a wonderful job. And I'm proud of all of you, and particularly I can see a lot of 2020 batch. I'm very happy about that. All of you are here.
sir, first, second, third,
Yes, Deepak sir.
who is the best among
Sir, very good afternoon, sir. Sir, happy Teachers' Day.
Hello.
Sir, happy Teachers' Day, sir.
Hello, Deepak.
Sir, you can.
Now I can see other people also. 21 also.
Sir,
Happy that all of you are here.
yeah, sir, I think so. You can hear the applause.
Yeah, I can hear that.
Very happy Teachers' Day, sir. And because of you, I am here today. Frankly speaking, sir, you are the one who motivated me, and you are the mentor and you are the architect of my teaching life. So thank you, sir.
I think then Deepak sir, what you are trying to tell is now I have not to sleep, and even in Delhi also I have to work with for you.
No, you left me on God, sir.
This thing, huh?
Sir. Thank you, sir. Thank you very much, sir.
No. Fine. Thank Shobha Gurdini madam patiently and chairperson Dr. Lata Devi.
Yes, sir. I'm here.
Ever enthusiastic Anuja madam.
Sir, happy Teachers' Day from my side.
Yeah,
Hello.
thank you, madam. Thank you.
And they have already announcing the 3 prizes, sir.
Yeah. No, but for me, all are the winner. Just
Yes, sir.
symbolically, first 3 is given. For me, all are the winners.
Sir, you are in the applause, sir. They are applauding.
No, I can hear that. But for me, all are the winners because they have moved from leap and bounce, and the presentation, depth of the subject, and all very amazing.
Yes, sir.
Good.
So we are
You
just.
can announce the prizes, madam. No issues.
Okay, sir.
Sir, happy Teachers' Day, sir.
Thank you, Anuja. Thank you very much.
It's a show. I'm Dr. Shobha, sir. Okay.
Yeah. Shobha, I can see you, madam. Now I can see you. You are doing a wonderful job in the institution. We are
Yes.
proud of you.
Thank you, sir. Ma'am, you announce, please.
Sir, this is Anuja, sir. Sir, happy Teachers' Day.
Thank you, Anuja. Very enthusiastic, Anuja.
Sir, shall I announce the winners, sir?
Yeah, I'm. For me, all are the winners. You just symbolically announced 3, but for me, all are the winners.
Yes. Sir. So now I request Deepak sir, Shobha ma'am and Lata ma'am to come over the stage. Please announce one.
Before they come to the stage, I request all the students to clap for the organizers, student members, office bearers. Give them a big hand. Because their enthusiasm is making us to drive very fast. And we should also thank Mr. Sajjan, who does selflessly. Sajjan, I want you to come on the stage. My request to all of you, give a very big hand to him. He's a very, very simple man, working very potential. Give a big hand to him. Good. He will give the first prize. It's the honor of his, he will give the first prize.
Okay. So we'll announce third prize first. Announce the third prize. Okay. Third prize, first third prize. So we'll announce third first.
Yeah, third you announce first. See, everybody has done the best. Huh? वो बोलते हैं ना आर्चरी में the wind blows on your side, you are the winner. So nothing. It is the beginning, and I'm thankful to sir. And yes, last time he asked me why you are not come for the presentation. Last time the CSC presentation was there. He told me that you missed it. Today I really felt, yes, you people are the best. I can really sense the knowledge, the way you are delivering. There are some ups and downs. We have also learned by giving more and more talks and giving more and more seminars and presentations, right? So everyone is a winner here, right? Don't consider that they are good today, that's all, okay? So you can do your best and you can win in upcoming events where you go, you all are going and participating, right? Thank you. And now we'll be announcing.
No. Deepak, before that, a few words from Shobha and Lata madam.
Yeah.
So every student has potential. Only thing, as the time passes, they should improve, because you were on a very good standard when you did the first event. So the same thing and more we expect in the subsequent case presentations. And when you are presenting outside, we want you to be very perfect. This is the initial, as I said, this is the initial case presentation as a rehearsal. So we want it to be more perfect in the next, that's all. And everybody has the potential, but you have to acquire it, that's all, okay? And all the best for your conference and the workshop presentation. And we look forward some prizes there also, okay? So we will now announce the first prize.
We'll announce the third prize.
Third prize, okay, third prize.
The third prize goes to
Prerana.
I request Shobha ma'am and Lata ma'am to give over the prize. This is the cash prize. It's not working,
Congratulations, Prerna.
The second prize goes to Rakshit Pandey. Now I request Dr. Deepak Chavan sir to give over the prize.
Congratulations, Rakshit.
And the first prize goes to Varshini Badagandi. Now I request Mr. Sajjan to give over the cash prize to Varshini.
Congratulations, Varshini.
Thank you, one and all. Thank you, sir. Now I call upon Vaishnavi to give the vote of thanks.
A very good evening, everyone. As we come to the end of this successful event, I would like to thank Dr. Shobha Ma'am, Professor of Department of OBGYN, and Dr. Deepak Chavan Sir, Associate Professor, Department of Surgery, for their precious time and insight to our presenters, who I'm sure will create wonders at the Osmicon International Conference. I would like to thank Dr. Arvind Patil Sir, Principal of Shri B.M. Patil Medical College, for giving us this opportunity and making sure that we are well versed with case presentation. I would also like to thank Dr. Lata Devi Ma'am, Chairperson of the Scientific Academic Research Society, Dr. Anuja Ma'am, Secretary of SARS, Dr. Anand Ingle Sir, Treasurer, Dr. Katti Sir, Secretary of SARS, for giving us this beautiful opportunity and for starting the students' wing so we could actively conduct events such as this. We are grateful to all our distinguished faculty members for their invaluable support and guidance. Your insight and expertise have been crucial in shaping today's event. And all the participants, thank you for your impressive presentations. The depth of your research, the clarity of thought, and commitment to your work reflect the high standards of our institution. Finally, I would like to thank all the office bearers of SARS for putting together this inspiring event, and to Mr. Sajjan and the entire IT department for working around the clock to make this event successful. Last but not the least, we thank the audience for your patience and support, and we look forward for more such enriching events in the future. Thank you.
This is called perfect presentation. Prepared slides, right? Give applause to her.
Sir.
Hello.
Sir, thank you so much, sir. In spite of your busy schedule and you being in Delhi, you could give us some time.
Yeah, no. That is my thing. I just want to see my students doing well. So we create time for them. It doesn't matter to us whether we're busy or not busy.
Yes.
Thank you, sir. Thank you.
Okay, thank you all.
Thank you, sir.
Thank you, madam. Thank you very much.
Thank you, sir.
Thank you, Isha and team.